So the recording is on now. Welcome, and this is a special Zoom session that has been organized in response to recent outcry. We may want to call it some media. Is it alarmist? Is it based on data? But what we want to do here is to look from an African perspective across the continent. What can we learn about the trends, number one? But also as specialists, we don't want to be reactive just the same way the public will be, but react from a point of what solutions are there, what is working. And here in the panel, we're going to have three panelists who are associates at the African Institute for Children's Studies. These are volunteer experts, and they come together in a pool that is made available for the rest of the public, the other players in the child development sector, to be able to inform practice and policy. So at this moment, I will give an opportunity to each of them to briefly introduce themselves. Do I begin with Dr. Michael Kiragu? Kindly introduce yourself, what you do. Yes, go ahead, Mike. And if you don't mind, if you can, yes, with your video, that's good, if you can. Go ahead, Mike.
Okay, hi everyone. It's a big privilege to be part of this associates team and to be speaking in this panel. I'm a public health consultant. I recently added grant writing to my portfolio of offers. I have a background in medicine and public health. Worked in the last 15 or so years in HIV prevention, cutting across research, service delivery, and policy advocacy. The last 5 years, I focused a lot on adolescent girls and young women, addressing sexual and reproductive health services, policy, and research among that population. So I'm looking forward to this conversation. Thank you, Sam.
Welcome, Dr. Michael Kiragu. Rosalind Were, do you want to go next?
Yeah, good evening, everyone. My name is Rosalind Were. I work as a social development practitioner, but I'm a social anthropologist. So I've also worked in the children's sector and the community HIV sector for close to 15 years, but in social development for close to slightly above 20 years. So I currently work in Zimbabwe as a chief of party for a USAID-funded PEPFAR program that works with orphans and vulnerable children and adolescent girls and young women. And I think my presentation will focus on some of the practices that some of the activities that we implement and how that has been able to curb, like for sexual risk mitigation, especially for the adolescents. And that also speaks to HIV, because then if it's sexual risk mitigation, then it's also HIV risk mitigation. Thank you.
Thank you, Rosalind. Dr. Murungi Nkatha, kindly.
Sorry, I had muted myself, sorry. Yeah, my name is Nkatha Murungi from the Center for Human Rights. That's where I'm based in South Africa. I'm the Assistant Director of the Center. I have a background in law, specializing in human rights law, and maybe more specific to vulnerable groups, that is children, women's, and disability rights. But I also teach sexual and reproductive rights at the master's level. So yeah, I think I have intersecting interests in children and sexual and reproductive health rights. And yeah, I'll be hoping that I'll be able to share a bit of that. Most of my work, my professional career has been with the African human rights system. And so quite a bit of experience from African Union mechanisms, the African Children Committee, the African Commission, and the relevant instruments across the African continent. Yeah.
Thank you, Nkatha. I think we really have a beautiful panel here, spread out with a lot of wealth of knowledge in the three areas that we want to look at. Maybe for someone who'll be listening to this for the first time, this webinar has been inspired by recent data from Kenya, where a media report indicated that one particular county had 4,000 girls who were reported pregnant in the last 3 months. And so this is being linked to COVID and the lockdown that has happened. So we want to respond to that and, hopefully inform the public conversation, but also the policy, and also look from a solution point, what is happening. But maybe to really find a basis whether this data makes sense, allow me to share my screen and present certain data that we has been, has come out from research and from government-owned data too. So I will do that in a minute. Great. Hope you can view my screen. I need to move this on the side. Great. So the first thing that went to my mind when this data came out was, is this really a new thing? Looking at various generations, has this trend ever been seen? Are we seeing a new spike in teenage pregnancies? Now, I've picked this from Child Trends. Well, its limit is largely a US data, but when you look at the data on the screen, the graph is showing that actually adolescent pregnancy rates have dropped over almost the last 30 years. Now, I know that we can quickly say, but that is global. When you look at this other graph for Kenya, now, this is between 1989 and 2014, UNFPA data, and that has been analyzed by a media group, but looking at the Kenya Demographic Health Survey, which is really a credible data. Again, you see a downward trend in the teenage pregnancy rates. Now, the most reliable data that we will pick on will be the Kenya Demographic, rather the DHIS, the Demographic Health Information Management System, which is a monthly data that is picked from facility. Here, I'm trying to compare quarterly data. And as you can see here, this is January to March 2017, and all the way to 2020. I've picked the particular quarter in which COVID should have fallen in, and that is April to June 2017. Oh, sorry, I didn't color the April to June. Let me just do it now. There is also April to June 2018, and then April to June 2020. Now, you sort of see again a graph that is dropping, but we need to be careful that June had not ended by the time we had this data last week. So perhaps that will change. But another caution in looking at this data is that it doesn't capture new pregnancy reported only. It also captures attendance rates. So basically it will be the same person attending monthly visits or quarterly visits, trimester kind of clinical visits that are expected of a mother. So this can be a bit erroneous. It's a bit unfortunate, but speaking to people who have access to this Ministry of Health data, they say that is a weakness that has been observed and hopefully it can be improved. But generally, I don't see anything very alarming in terms of this particular year's April, June, as compared to the other years. The other thing I've picked, so this was for this was for 10 to 14-year-olds. When you pick the 15 to 19-year-olds, again, there's something about 2018. We seem to have had a higher teenage pregnancy rate. I don't know why, or attendance rate by mothers compared to the other months. Again, the 2020 figure seems to be low. Now, this was the particular county that really brought in all the conversation, Machakos County in Kenya. This is antenatal care attendance rate. Now, again, looking at that, nothing very different. The trends don't even seem to be necessarily showing that there's a spike in that particular quarter for this year compared to the other years. Now, I know maybe this one last one. When you look at the global statistic on this, overall, there's been, this data says there is a decline in unintended pregnancy, including overall, but that is not, the drop is greater among the developed countries. So meaning there's something about countries that are more developed and the least developed, or something about poverty rates or income rates vis-a-vis the risk of pregnancy. So with this, I want to really throw it out to all the panelists. Mike, you can go first. Is the media simply being alarmists? Is there anything to worry about teenage pregnancy rates, looking at this kind of trends that we have for Kenya?
Yeah, thanks, Sam. That's some really useful data analysis. My take on the data is, first of all, it's really knowing that many of the women in our country attend ANC, antenatal clinics, much later in the pregnancy. So any effects that are related to COVID we'd have to wait for maybe 1 or 2 more quarters for us to make a conclusion that whatever pregnancies we are seeing are related to COVID. It is, on the other hand, it's alarming that, you know, teenage pregnancies are not coming down sufficiently to the level that we really want. You remember 2018 was the year when all girls were supposed to have been transitioned to schools. All young people are supposed to have been transitioned to school from primary to secondary. So if that has not translated into reduction in the number of teenage pregnancies, then there's still more work to be done. There is still more work to be done because I know DHIS, and I think this will be another analysis that we can look into a little bit more. Proportionately, it seems that the number of teenage pregnancies is on the rise. When you compare all the proportion of pregnancies that is within this age group, you can see there's actually a higher number among, it has been increasing. I think last year's data was about 40 and has been approaching 50%. So you can imagine if 10 to 19 year-olds are the ones who are having 50% of the pregnancies, it basically means that there's some disproportionate reduction in fertility rates, lack of access to sexual and reproductive health services, contraception, information seems like it's not getting to that particular proportion. So, and I know the challenges with programmatic data, the disaggregations are not very meaningful at this time, but I think maybe as we move forward, that could be something that we want to look at, and we want to push the government to do better disaggregation of this data so that we can figure out exactly where the problems lie. You know, we say we get a report of 15 to 19-year-olds who are getting pregnant. But if all those pregnancies are among 15-year-olds, even within that age group, then we are a country that is in problems. But if, on the other hand, if data shows that it's 19, 18, and 19-year-olds, then maybe we are not doing so badly. So better disaggregation of data will be much more informative as we move forward, so that we'll be able to make better decisions and pinpoint where the areas are.
Thank you, Mike. I know we'll come back later and you tell us from sexual reproductive health and rights perspective, what will be some key things to think about. I know there's been the conversation around, should we give access to teenage girls use of contraceptives, for example. There was reports in Kilifi where mothers said, I just want my daughter to be able to complete her education, so I would rather she gets access to contraception and so that she can complete. Is that correct? Are there certain risks? And how do we manage that? But Rosalind, if you can come in on this data, and particularly also the question of, are there school holiday periods that we see overall increase in teenage pregnancy? And like as Mike has said, there's a chance that the teenage pregnancies that are due to COVID restriction period and all this vulnerability that is increased will be seen 6 months later, because a lot of unplanned pregnancy, people don't even notice them maybe until the 3rd or 4th month. So maybe it's too early. Your thoughts around the data?
Yes, looking at the data, and I think looking at it from my professional lens, it does tell a story of what happens to the adolescent girls. But what I am not very sure about is the spike in numbers, because it's too soon to actually quantify the number of adolescent girls who are already pregnant as at this point. Having been an adolescent girl some years back, if I engaged in sexual risk behavior, one thing that I'll try to hide from my parents is a pregnancy, especially within the first 3 months before it shows. And my parents would only get to know when it's now showing, or when I'm already demonstrating the signs and symptoms of pregnancy at home. And we know, I mean, that's how a normal, typical adolescent girl, especially 9 to 14 or 9 to 15 would behave, or 9 to 17 would behave, because of the fear around parents or caregivers knowing that they are pregnant. So when I saw the data, especially the media data, not the data you've shared, one thing that came to mind is, so what's the source of the data? And what's the age of the pregnancy? So that it's linked to the COVID period, because it's only the age of the pregnancy that will link that to the COVID period. Not refuting the fact that, yeah, pregnancies do happen, and the most times that these pregnancies happen is normally during the December holidays, because of the festivities that come around those holidays. The spike is normally higher during the December holidays as opposed to the other months of the year. But COVID has come with new dynamics at family level, at community level, and we can't say that children are not engaging in sexual risky behavior at this time.
Thank you, Rosalind. Nkatha, as you come on, I mean, it appears like school holidays, or school for that matter, is actually a protective factor. So the question of, could this be something that is pointing to the overall drop or decline in number of teenage pregnancies over the last 20, 30 years? Because perhaps there are more girls now attending school. But now that we have this access to social media, you know, our Minister for Education has come out very strongly and said, you must make sure that pornography is not accessible, because that could be causing the problem. How does that play on access to information as a right, especially sexual reproductive health for children too? And what's your take on the data too?
Thank you, Sam. Well, the 2 questions in one. So let me start with the data. I'm not a statistician, and lawyers fall very far from that demographic generally. But there is one thing I can tell you for sure, that even to me, the untrained statistician, the data looks fishy. You know, I kind of think like, okay, that spike looks a bit unnatural. What is it about the reporting? What is it about the data gathering? I'm interested. I'm intrigued. Not so much because I think that it's true, but so much because I think I want to understand how we got here in this data collection. So I I think for me, of course, it still affirms one thing, that we do have a teenage pregnancy issue in the country. The magnitude of it is an issue, but we need to first acknowledge that this teenage pregnancy is not an issue that we have solved. And then we need to start thinking about, okay, if this is really a true reflection of the magnitude of teenage pregnancy, then what are the most ideal ways of responding to it? And I will speak from a legal perspective, because even from a legal perspective, as a lawyer, I am very hesitant to see solutions as being legal to this issue. There's a broader issue at hand. And so the law would only play a certain role. So I wouldn't really, overhype how much the law can solve or not solve this. In any case, I hope that we'll be able to come back to that discussion as we get along. Schools and teaching has been a contributing factor towards the reduction, the progressive reduction of teenage pregnancy.
Great, thank you. Thank you. Thank you, Katha. Are you there? Yeah. Okay. We lost you at some point. Do you still want to build on the point? You still want to build the point on education as a factor?
Yes.
And also the question of rights, access to the right of access to information on sexual reproductive health generally.
Okay. Yeah. So on education, I was saying that it is very evident that education has a role to play in how children or people, adolescents experience and express their sexuality and sexual reproductive rights, the exercise and access to. In the sense that obviously within the children's rights movement, we speak as if education is a very separate idea, but education is really a means to protection of children from many other things. Education is also a means of protecting children from child labor, for instance. But one of the, it's not purposive, but one of the consequences of having children in school is that there are structures in place that facilitate protection and that keep them from certain practices and exploitation. So obviously, education has worked, one, in terms of those structures of protection, but two, that the more teenagers, the more adolescents are aware, the more educated they are, the less likely that they will make choices that jeopardize their welfare. So there are those two elements. Education as an empowerment tool, but education also as a protection tool. Regarding access to information, I was a bit ticked off by Professor Magwa's comment, for the reason that, I was starting to say earlier that when you conceptualize something in a very simplistic way, and then you tend to give a very simplistic response to it, and it doesn't solve the problem. So to simply summarize the issue of teenage pregnancy into access to pornography is a bit insulting to the intelligence of the entire country, because pornography has been there in the various forms that it has been there. It doesn't explain the spike. Of course, teenagers currently have maybe more access to media, but that has been a building and progressive process throughout. Experience across the continent shows that the more teenagers are exposed to media, the more opportunities for development, yes, but also the more mischief that they will be up to. So the issue is not about criminalizing what will eventually anyway happen. You cannot block pornographic sites because they are VPNs, they will still access. What we need to address is the behavior underlying the need to consume pornographic material. So one of those issues is the general rule, the general human rule is that if you keep something from someone, they become more interested in it. And that is particularly in relation to sexual reproductive health rights information. So teenagers still find it. They just find it in the wrong channels. And if the education system, if our society is not prioritizing transfer of relevant information that empowers teens to make decisions about their sexuality, to be well informed, to know that this is harmful content to me, then just blocking the content will not resolve the issue. Yeah.
Thank you, thank you. I know when you come back to looking at the legal options, there's been a thought around, should we sue parents for neglect? Can the chiefs in the villages be held accountable for pregnancy of girls in their community? There's been some of that as local solutions that have been made. But back to Mike. Mike, from a public health point, what will you say should be some minimum things in responding to preventing teenage pregnancy? And I want to believe all of us as panelists here, plus the associates that have joined, I well appreciate that one teenage pregnancy is much too many. It's you can't say that it's okay even if it's just one. So we want to get to a point where it is zero. We know it's almost very idealistic, but what will it take, Mike?
Some years ago, I was privileged to be part of a Kenyan team that was looking at a nationwide campaign, a South African nationwide campaign that was called She Conquers. And the aim of the team was to look at this She Conquers campaign and see whether it's actually going to be replicable in our country. And one of the things that we learned in that whole process is policymakers, healthcare providers, and many people actually in the community look at this issue as the sexual reproductive health issue of adolescents very simplistically, as Nkatha put it. It's very simplistic to think that we can come up with a magic bullet that solves everything. You stop pornography and it sort of kills everything. That many of the girls who end up having teenage pregnancies are involved in a very complex social issue that cannot be solved by one person. And yet, when I sit on the table with policymakers who are addressing sexual reproductive health issues, you go and find people who are doctors like me, just doctors who are seated there. You don't have people from the education sector. We don't have people from the legal sector. So we are talking to ourselves, and that's a big gap because we are not looking at it holistically. In She Conquers, the girls actually told us, they told us what the network of issues that they were addressing that were facing them at home. There are girls who don't have food to eat. There are girls who access to information, even as we are saying that phones are accessible. When you look at data, even on access to phones, you see it's really skewed towards boys. Even having information that is accurate, there's a huge disparity between access to information among girls and that for boys. There are lots of issues. So one of the things that I really I'm a big proponent of is working around a social movement that involves everyone. That we say it's our right, it's our responsibility as a community to protect girls. So that the healthcare worker, when this girl shows up at the clinic, the healthcare worker knows that it's my responsibility to ensure that this girl has accurate information. That it's counterproductive for me to be judgmental towards her when she asks me for contraceptives. And it should be, even the teacher should feel this movement that is delinked from politics, because politics is what kills this thing. It's, they go for the things that are popular. That's why you would say something like pornography. You can only be a politician to make such a statement, because you are going for the popular route. But it will be much more unpopular for him to say all girls should have contraceptives, or all teachers should give a session or two around sexual reproductive health and rights every week to girls within whatever setting they're in. It's really unpopular. So a social movement that's driven by our communities, that's driven by civil society, for example, who are not going for popular acclamation. We are not going for accolades, but we are going for what is right. We are going for what has to be done. And what has to be done is not popular. It's not, not everyone is going to cheer us, but at the end of the day, we'll have protected the girls. And as we build this movement, I know many more people, even the politicians, will follow over time. Second thing that I really think that needs to be done is data that is meaningful. We need data that's meaningful. You know, a study that puts in 15 to 44-year-olds and looking at pregnancies in that rate. I mean, maybe on a macro level, it helps in making decisions for economists, but it doesn't help public health decisions. So there is need for data that is really nuanced by region, by age, as well as all the social drivers that are involved. We need more data, we need more information to make sure that this happens. So for me, those are the two key things that we need to really do to make this happen.
Thank you, Mike. The emphasis that this is not going to be a one sector business, and that it has to be evidence-based data that makes sense. Definitely we'll come back to this also once we respond to the questions that are emerging. I want to give an opportunity to Rosalind. Having worked in this sector and appreciating that there are a lot of social determinants to this health, so to say, issue. What's your experience? What has worked? And you can share your PowerPoint if you do have. Feel free to share your screen. You are muted, but I think you can go ahead and speak. We can't hear you, Rosalind. Are you speaking? Maybe you're muted.
No.
Okay.
Are you able to see?
Yes, we can see
my
your
presentation?
screen. We can see the screen,
now
but
I'm not
not the
able to.
presentation.
Oh, Jesus. Okay, fine.
Just open it.
It's open.
Oh, okay.
Oh,
Yes, it's
there.
open.
Oh, it's open.
Mm-hmm.
Yeah, so I'm going to make a presentation that just speaks to the work that I do in Zimbabwe, and some of the results do not have data, but just mention some of the results we have seen. So I work on a project that reaches out to orphans and vulnerable children 0 to 17. And then we have a specific intervention that targets adolescents, both boys and girls, 9 to 14 specifically, and then adolescent girls and young women, 9 to 24. But my program targets the 9 to 18-year-olds. And what we do, so who's involved in the work that we do? So one are the boys and girls aged 9 to 17. And we target those who are in high GBV, HIV hotspots, because of the realization that in areas that are high GBV, HIV hotspots, the incidences of those children getting engaged in sexual risk behavior are high, and the incidences of them also having cross-generational sex are high, and the incidences of them getting infected with HIV are also high. I'm not even talking about the SRH challenges then that they experience in those areas, again, because of the GBV piece. And the other people who are involved, they are their parents or caregivers. And most of the parents are people like you and me, but mostly, again, the poorer population in the community, the older population in the community, because those are the ones who are mainly caregivers of children who've been orphaned because of HIV, or as in the case of Zimbabwe, we have a lot of parents who've immigrated to South Africa, and the children are left with their grandparents. And then the other cadre of people who are involved are their peers. So we have a strong peer support program also that brings these children together. And especially by those like where we target teen mothers, we have peers from the teen mothers cohort who are the ones now who reach out to the adolescent girls and reach out to the adolescent boys to just tell them what it means to engage in sexual risky behavior, what it means to be a teen mother, what it means to be 13 or 14 and pregnant with your parents not in the country. So we have a pool of peers, and when I get to one of my slides, I'll explain who those are and what they do. And then at the community level, so we work with different people in the community level, but mainly we have community cadres whom we work with, the community child care workers, the village health workers, level who also reach out to these children and also reach out to their parents and caregivers, and also to other community structures, including churches, the faith-based community, the schools, the community opinion leaders. And then we work with other stakeholders, so those would be CBOs, the NGOs, the schools, and other community structures, formalized community structures. And finally, we also work with the government structures. So the model that we use to implement this intervention is the socio-ecological model. Sorry, I didn't cite the source because I was just trying to add this when I had a chat with Sam in the afternoon, and I was already doing so much else. So on this model, so we have the individual who in this case is the girl or the teenage boy, because you know, like I've talked about cross-generational sex, but again, much of the sex that also happens that leads to these girls being pregnant is from their age mates. So you find a 13-year-old who's made a 12-year-old pregnant, or a 15-year-old who's made a 16-year-old pregnant, and all that. So we target the individuals at this instance. And for us, our entry point is the adolescent, boy or girl, who's at risk of engaging in risky sexual behavior. Or in the case of the girls, an adolescent girl who's selling sex, an adolescent girl who's a teen mother, or an adolescent girl who is in a high HIV, GBV hotspot, or an adolescent girl who is not in school, especially from the lens that education is a very strong social determinant of health, and that education is also a driver that makes girls not engage in risky behavior, especially girls. And then, so at the relationship level, we have their family. So that's where we target the caregivers. We target the peers of the adolescents. And in some instances, even the sexual partners of the adolescent girls who are selling sex, or the sexual partners of the teen mom. So that's also a cohort that we target. And then at the community level, we now target the community structures, the schools, the churches, the faith community, the social structures in the community, the social groups, the women groups, the youth groups. And that also touches on the societal, where we have a very strong element of gender and social norms change. And then at the government, working the capacity of government structures and working with the government structures. So on my next slide, I just want to explain, get into a deep dive and explain what it is that we do with each of the categories that I've talked about. So for the adolescent, and here we have the boys and girls aged 9 to 14 and 15 to 19. One is that we have a positive parenting model. So in the positive parenting model, we implement a curriculum called Parenting for Lifelong Health. And this one is facilitated for caregiver teen pairs. So meaning that it's a 14-week module, and those who participate in the module are the teens and their caregivers. And what this has done is that it has opened the door. You know, as being Africans, there are things sometimes we don't discuss with our children, but it has opened the door for these children to discuss their fears, to open up to their caregivers, And what the facilitators do is that they are given assignments, and when they miss a session, the facilitators follow up at the household level to find out what happened and to be able to address some of those challenges. And then there's a community level graduation. And what this has done is that it has made us actually open the door for some of the things that happen in secrecy that put these girls at risk. We have had instances where children will even mention that there's someone who's defiling them in their household, in their home, a grandfather, an uncle, a nephew, a brother defiling them, has taken them for an abortion. So these sessions really open the door, and it gives the girls, especially the girls and the caregivers, confidence to be able to become closer to the adolescents, get the skills on how to talk to the adolescents on issues that are considered an-African, because we no longer do not have the auntie system where the aunties would talk to us about this. And then, so we have that, and it's been very, very successful. And in the districts that we work in, every adolescent to 15 to 19 must participate in this session with their caregivers. And what we've had is that we've come up with a caregiver support group that only focuses on positive parenting, where if I'm scared of discussing certain issues with my child, maybe about my behavior that might have influenced them to pick the risky behavior, then another caregiver who is in my group then can go and talk to these children about that, and to open the door for me now to be able to talk to my children and even tell them, I'm sorry for exposing you to some of the risks that the kids experience. And then we have a father-child dialogue guide, and we realize that this is very critical because of the role of males in forming character and even helping alleviate some fears that children have at the community level. So what we do is we identify a male figure in the family or in the community then who has dialogue with these children to discuss issues that they would otherwise not discuss with an male figure. And it's a guide that helps them open up on different areas, and especially on areas around sexuality, their sexuality, their fears around sexuality, the unknowns around sexuality. So getting to discuss that with a father figure, a father male figure, that one has also been very, very important. And then we have now the peer support group. And the peer support group that we have, so it's just a group of girls whom we've trained, and those who've experienced gender-based violence, those who've been teen moms, and they're all teenagers, those who've been teen moms, those who've experienced gender-based violence, those who are selling sex and have moved out of that, so that they become peers to the other children, so that the children have someone they can go to when they have a fear. And one reason why we do this is that, like I mentioned, it's not easy for a girl who discovers she's pregnant at 1 month or 2 months to open up and say, oh guys, I'm pregnant. But it's easier for these girls then to reach out to their peer and tell them, you know, I've missed my period for a month, I've missed my period for a second month. So then they're able to access health services on time, and also access the support services, the community level support services on time. And then we have a life skill model that also now helps them also build their life skill, build their confidence. And we use a model called Passport to Success, but we also have a lot of social asset building interventions that they also go through to just give them the confidence. And it's done through schools. So meaning that even if we have a cohort of girls or adolescents that we work with on our program who are benefiting from this, but because of the platform where this is provided in school, then it means that in that community, all the children in school in that community get to access the services. And then we have cognitive behavior therapy, because when a girl becomes pregnant, most of the time, if the person who's made them pregnant is older, there's a lot of coercion, and there's a lot of power play, especially if this person is not of their age. And there's a lot of also mental trauma that happens with that, and the shame and the community shaming and naming that happens when a girl is found pregnant. So we have community level cognitive behavior therapists who these girls can also go to just help them deal with the mental trauma. But what we've realized, and this has been talked about, mentioned by everyone, that education also becomes a very good platform. Keeping these children in school opens their mind and gives them a vision that then minimizes their engagement in sexual risky behavior, and in that instance also making them not get pregnant earlier. So at caregiver level, besides the joint positive parenting sessions that happen with the child, for us when the positive parenting session happens, for us the person who's at the center of that for us is this teenager, because then they are able to get a service, or they're able to get access to information and strengthen their relationship that will keep them safe. Vulnerabilities at the household level that expose these children to risky behavior. So household economic strengthening happen in a cyclical manner. Like if my mother was a single mother and she went through a lot of trauma, mother also become high because of that. I mean, like it's just, I don't know, let me not talk about that now, but just trying to also help the mothers and the caregivers deal with their own issues so that they are better able to parent the teenagers and handle the teenage rebellion and handle the challenges that come with the relationship between them. And then legal
Hi, Rosalind. Am I the only one who's losing you?
that there's justice for them, because that also helps them feel, but also gives them confidence to take care of the other children and make sure that the other children do not go through the same phase that they went through and the same phase that their adolescent has gone through. And then at the community level, we hold community dialogues. And in these community dialogues, we even share the data with the community members of maybe the girls who've been pregnant at that time, in that period, and why, of the gender-based violence cases that have happened in that period and why, the platforms that exist for reporting, platforms that exist for referrals to other services, the platforms that exist that can help these people. And then we implement the SASA model, and that is just a model for community action groups, where now you come up with a pool of intergenerational community gatekeepers whose role is to also mentor the same young girls, the adolescents, so that now they can know that they have a community level support system. So these are what are they called? These are suggestion boxes, similar to the suggestion box model that are in the community, in the school. If a child realizes there's something happening, they can drop information in that box, and it's opened every week by the same children anonymously, so that if there's anything dangerous that is happening in the community, then the community is able to get access to that information on time and respond on time. And that can keep a girl from getting pregnant. And then we have community drama clubs that will then, based on the information they get from the suggestion boxes, they'll come up with drama skits. So that's a social behavior change model that will come up with skits that will help community members know that this is what is happening in our community, this is how we can prevent it, but should it happen, this is where we can also access other support services. Then we have radio campaigns. So we also have a lot of social and gender norms discussions that happen during the community dialogues. And the community dialogues bring together community members to just discuss the issues that are informed by the dynamics that are happening in that community. And then with the government, we work with the ministry, the Department of Social Welfare, the Ministry of Women Affairs, the Police Victim Friendly Unit, and the Ministry of Primary and Secondary Education. Because ultimately, when these incidences happen, these are the first government structure that will handle the incidences, so that they are sensitized, they know what to do, they know how to provide the services, they know how to do the sessions in schools. So sometimes they do the sessions in schools to just explain to the children that, yes, should anything happen, this is where you can go, this is where you can access services. So how then are we able to know that we are making a difference? So we have a very comprehensive case management system. And for the case of Zimbabwe, Zimbabwe has a national case management system that starts from the community level, up to the national level. So at the community level, there are community child care workers, there are community child protection committees, adult-led, and they are also children-led. So the children at the community level also have their own child protection committees. And through this, the pillars of hope now are the point people for this component who sit in these child protection committees and who are able to make sure that the girls get access to information on time, access to services on time, and are linked to a counselor or whatever service they need on time. So the national case management system in Zimbabwe is something that I find to be very unique because not so many countries have, like Kenya, my home country, doesn't have that national case management system that is owned by government that you can report to, like even a child can report to through that system and be able to access services. And then we make sure that in every ward that we collect monthly data across the different indicators on the interventions that we have, and share that data with the community members so that the community members then can know whether they are now a safe community for the adolescent girls, or if they are not safe for the adolescent girls, so that they can know what it is they are able to do. And then there are safe spaces for children to report. And this is mainly, like I was talking about, the suggestion boxes in school. Those ones are safe. Then we have a national toll-free number, and we have 2 national toll-free number. Besides the child line 116, there's also a toll-free number for reporting gender-related issues and gender-based violence-related issues. And this, I think that mix of so many services has really helped enlighten communities and make them safe for the children, even within the COVID period. Because even for the last time since we had the lockdown, we have not had incidences of pregnancies reported. But like I'm saying, if the pregnancy happened yesterday or tomorrow or last month, we'll most likely know about it close to delivery. But we've not had instances where that has been reported. What we've had is that we've had cases of very many children calling the toll-free number and just asking for information on issues they are worried about. And that is already a plus. So that is data that we collect monthly on how many children have called each of the toll-free numbers and what issues they are raising. And when they raise those issues, then that's what we do. We pass on the information through radio media campaigns, through WhatsApp flyers, and through bulk SMSs because of the COVID lockdown. So that has helped. And the other thing that I didn't mention maybe is that we have, in every of the districts that we work in, we have a shelter. So in this shelter, if a girl feels like their life is at risk at home, they can run to that shelter and get support. And that has really helped because they know they have somewhere to run to. And immediately they get to the shelter, then they get linked to the Department of Social Welfare, the Ministry of Women Affairs, the Police Victim Friendly Unit, and any other community level support structure. So that's my brief presentation, and thank you. So I'll welcome questions.
Thank you. Thank you. That was very comprehensive. I'm sure there's going to be, they call them a barrage of questions. I mean, and perhaps your email address for those who want to learn more from Zimbabwe. But thank you so much for pointing us towards very good solutions. Before we go to the questions that have come alongside that, especially one that someone, I think it's Rahab. Rahab has asked, how do you handle, let me just get to her question. How do you go about navigating the well-known teenage tendency towards the rebellion? So you've mentioned how you've worked with teenagers and the fact that they'll be curious and all that. How do you manage that? But you can answer it later on. Let me ask Dr. Nkatha Murungi, kindly, there's been always the thinking that where are the perpetrators? Why are we not arresting them? Is there a solution? Has it been shown to work anywhere? That when you have very stringent, very punitive laws, and we are very effective in tracking all people make the teenage girls pregnant because it is a violence against children. It is sexual exploitation. But also, how do you handle teenage boyfriends in that case?
Thank you, Sam. So I think I cannot respond to you unless I go a little bit back. So just allow me some minutes to to contextualize, because one, I must say I'm very impressed by the presentation of a model that is working on the ground. And Rosalie, I'm not too sure, but I met a certain model that works in the same way implemented in Zambia. And it was on one of my notes to recommend that we probably think about that. And it's related to the work that Rosalind is doing as well. I think it's run by UNFPA/UNICEF, I'm not very sure, but it works on the same basis. And I think those are some examples of what is working. But let me just come back to what, measures of accountability, but more thinking from a legal perspective about this issue. And I think I start on that by just bearing my own frustrations, because this is part of how we ended up here, because I ranted on another platform where we all are. My frustration is usually that when this dialogue comes, people they foreground the law very quickly and start saying that we need to adopt laws, to address this. The law is not sufficient, and maybe if we have better laws, then we would not be where we are. And then that conversation becomes also highly emotive, and it becomes emotive because first it's driven by significant assumptions. And when we have then the significant assumptions drive people to retreat to their own, moral consciousness, and then we start projecting. And so it becomes a deadlock. And when you have a deadlock, then there isn't really proper recommendations of solutions that are based on fact. For instance, when you refer to the data that we were speaking about earlier on, obviously we see that that's data that covers 15 to 19. So we do have a cohort there of 18 to 19. We don't really know how much adolescent, within adolescent and children's rights sectors, and who then are we applying the information to. There is not to discount the fact that maybe, if we have more 18 and 19, it's not a children's rights issue, but it's still an issue within the country. But if I was speaking from a children's rights perspective, and in law, we like to be very specific about age. We want to know that we are talking about children who are between 12 and 19, because the legal regime is different if you're applying it to 18, 19, and if you're applying it to 17. For instance, for the purposes of questions of defilement, for questions of punishment and things like that. But I think that is secondary. So from my point of view, I think one of the primary issues that we need is value clarification. And I know we talk about value clarification in a very different context, which is a bit controversial, that we don't usually engage with. Usually value clarification comes when you talk about issues to do with access to safe abortion. That's not what I'm talking about. I'm talking about value clarification in relation to adolescent sexuality and sexual reproductive rights. And just to be sure about what we are saying that regulating certain things does not mean that we are regulating morality. Or if we want to achieve morality, the route is not necessarily the law, but rather that what you're trying to do with the law is to further certain protections. Morality is a scope of a certain different discipline that is not necessarily law. So there's a conversation that we need to have around value clarification. Why do I think a certain way about sexual reproductive rights? Why is my view perhaps different from someone else? If I grew up, like personally, I grew up in a Christian conservative kind of background. Obviously, I have certain views that are informed by that. However, when I come to a national level and I'm a policymaker, I also have to remember there is a child who grew up without a parent, who is probably living on the streets and who is experiencing life extremely very differently. And their value system is not my value system. So we need to have a conversation on value clarification, what we agree on, and how do we then translate that into law. I think we are not doing that sufficiently. The second thing is that when we are talking about teenage pregnancy, we are not correlating all the factors. Like for instance, within that data that we are now collecting, we are sustaining a single narrative of sexual exploitation. It's true. Most of the young people who actually have, who get pregnant, you can say they are sexually exploited. However, that's not the complete narrative. And it's dangerous because when you go to the sexual exploitation narrative, then we are bound to see a violator and a victim, and then to respond accordingly. And there are people who are in that continuum that are neither, violators, neither are they victims. And someone I see on the comments mentioned about Romeo and Juliet situations. And there is Romeo and Juliet situations, and we need to know that it is actually a fact. Adolescence by its very nature is a stage that it is very testing for the adolescent, but it is also a very dangerous and vulnerable point of view. The child they are a child, but they are coming into adulthood. And most of the time, they actually don't have as much control over their impulses as we think. If you consider this child as a violator eternally, then you take a certain response. So there's so much stigma attached to adolescent sexuality that we are addressing it from if all you have is a hammer, everything is a nail. We are not seeing the full continuum of, okay, from the point where they become a victim, their vulnerability, how do we respond to that? What is the rehabilitation? What's the full cause of the law? I think that is one of the things that the law needs to clearly define. So do not be obsessed about punishment, but be in a position to liberalize the approach enough that we are able to, one, prevent children from being criminalized for, ordinary adolescent behavior. And two, to not punish children for failures of the society. Because one of the things I do when we do these trainings is I always ask people, why are you a child rights advocate? Why are you an advocate about certain things? None of us says this because the law says that I cannot do this. It is because of a certain personal experience or a personal value that we learn at a particular point in time. So the issue is that we are not investing enough in those personal experiences, which happen through conversations and dialogue, through engagement. And then we want to use the shortcut, which is the law, by telling children that they cannot do this. A majority of us are not what we are because of what the law said. We are what we are because of the formative values and collective experiences that we have at childhood. So I think that is also something that is missing. So if I think, from a general point of view, the correlation between regulation and the prevalence of child pregnancy, for instance, it's not as much researched. However, I work in a country where, South Africa, that has one of the highest rates of teenage pregnancy, but also has one of the highest rates of other problematic issues, such as sexual violation. Sexual violence I think South Africa has one of the highest rates of that. And the story of teenage pregnancy in South Africa has a lot to do, of course, with social inequalities, but also the history, but also the vestiges of that oppression. So it becomes a form of oppression, and teenagers internalize these things. And the reaction to that is that, the way teenagers see their role in governing and taking control over their own lives has something also to do with their sexuality, because a lot becomes, centered on sexuality. So what I'm trying to say is there's academic research out there that shows that those factors vary from country to country. The point is we need our own Kenyan defined understanding of what are our contextual, correlated factors that are driving teenage pregnancy. And those are not necessarily because children are sitting back at home. Those could be some socializations that we have also come to adapt as a society. If you embrace rebellion as a way of work, it also tends to manifest in other areas, whether the children, the school system, the political system. There are certain cultural factors, social factors that we need to think about. So I think that study has not been done sufficiently within our context. But what is becoming more and more increasingly clear is that when you try to use the law when you over-regulate, then what happens is that children become casualties. So it does not eliminate the problem. It just increases children's difficulty in interaction and in their development. So basically, criminalizing adolescent sex, for instance, does not mean that there will be less sex. It just means that there will be sex will still go on amongst adolescents, but it will be underground, which means if there is a risk of violation, there is no avenue for redress. Because if the law says that adolescent sex is illegal, then there is no way a girl will have the confidence to go to the police and say that so-and-so violated me, because she in herself will be reporting herself as a criminal. And secondly, it also makes it very, you know, if you criminalize and remove something from the system, then the policy responds accordingly. So even the girls who are in such highly exposed situations and need the redress of the law, for instance, such as access to emergency contraceptive, they cannot, because the policy cannot foresee a situation where a child will need access to contraceptive. So these discussions are interlinked. And the way we phrase the law sometimes is like we are trying to use it quickly to react to something, but the consequences are enormous and they change the narrative entirely. So I think if we have more time, I would wish to share. But in my view, I think the things that we really, really need to keep in mind is that the approach of international instruments, such as the CRC and the African Charter on the Rights and Welfare of the Child, is that they are actually sympathetic to the child, to the pregnant girl. The approach is sympathetic to the pregnant girl, in the sense that the narrative needs to be from a point of view that pregnancy doesn't change the fact that they are children. The way you treat them must be in a way that, you know, still furthers their best interest, does not reproduce discriminatory attitudes, you know, the stigmatization that is a manner that safeguards dignity. If we don't safeguard the dignity, it's extremely difficult to then see how, you know, we re-engage at a later stage, even to probably address the issue. So really, the law should be more working towards preventing extreme marginalization of girls and extreme exclusion on the basis of their sexuality, and more towards, you know, allowing adolescents to be able to be adolescents without being necessarily criminalized and challenged for permanently.
Thank you, Dr. like they say. Mike, boys can easily access condoms. Should our teenage girls also be able to access condoms?
Yeah, sure. That from the outset sounds like a no-brainer, but really it is something that's really complex. Again, I think by right, they should have access to contraceptives. They should have access to condoms. But when you are talking about telling a girl to go to a family planning clinic. She has no family. The contraceptive, the health services and the structures are not built in a way that the girl can access them. They are not structured, they're not packaged in a way that girls can have access to. So we'll say that, well, anyone can pick condoms, but you're not going to see the girl picking the condoms. You're not going to see the girls going to pick the contraceptives, because there is a particular aspect of it that is just not addressed. These services, these products were not designed for this population, and there is really need for a lot more work to make sure that these products are not only accessible, but they're also appealing to these girls, to make sure that we achieve whatever it is that we want to achieve. One of the things that I just wanted to also include is that I think in Kenya we have some of the very best policies, and but all of these are pushed aside and not implemented. There are lots of studies, lots of policies that support delivery of girl-friendly services. Those exist in shelves, they exist even within government offices, but they are hardly implemented because and I'll go back to my point, because it's not popular, because it's not being pulled by the society. You know, the girl has to go to a health facility to collect contraceptives, but in the end, her use of contraceptives has to be sanctioned by the community. It has to be sanctioned by the people who are around her. So if it's not something that she's supported to do by her mothers, her sisters, her aunties, her friends, her teachers, then we are not going to move forward with whatever it is we want to achieve.
Thank you, Mike. I think you've responded also to what Dr. Sheila has just mentioned, that in the chat, that there used to be something called youth-friendly clinics or centers. Do they still exist? But I also guess, like you're saying, socially that may not be approved for a 15-year-old to walk there and pick a condom. And maybe it goes to the whole conversation we've had in Kenya, and I don't know how many other African countries, on whether we should have sex education and sexuality in school and how that should look like. But I'm thinking with the concern we have in terms of the sustained number of pregnancies, though from the initial data I shared, seems to be decreasing over time, maybe the benefit of access to education, but also the fact that we could be having more girls, are they able to access clinics? Because that is an important thing. The drop could also be that our clinics are not friendly for adolescents, so they are not going anyway, so that the data we are having is actually dropping. There's so much that we need to break down and understand behind the data that is being shown on that. Let me scan through the questions and see who needs to answer. I will give you about a minute each to give your summary, your punchline, what you really think should be done. And then I will summarize on the bullets that I have taken notes from. Let's see if there is any unanswered question. Maybe the question of policy. I see a conversation here. I think Paul Musangila was responding to Juliet and saying, what about the policy environment? Any of you can come in on that, maybe Rosalind, and your experience in Zimbabwe. Is the policy environment adequate? Is there a willingness to talk about sex, even among adults? Rosalind?
Yeah, the policy, I could say the policy is adequate. What is a challenge, I think, is the interpretation of the policy. I remember just at the beginning of this year, donors wanted to introduce comprehensive sexuality education to children, and the government has a policy. The government has a policy, guidelines, and standards that even demonstrate how this should be done. So, and where it should be done, and to who it should be done, with which content. So the challenge that then arises sometimes is balancing the African and the Western. Because sometimes, like what I remember the minister was asking us, I know you have a 9-year-old in your house. Would you tell them the things you want to tell Zimbabwean children in school? Yeah, because you want to tell Zimbabwean children in school on comprehensive sexuality education about masturbation as a safe sex. You as part of safe sex, you want to tell this 9-year-old on contraceptives and all. And we're saying, look at what we have, tell us what's the gap in what we have, it will strengthen it. So the policy is actually for Zimbabwe actually there. The community structures are strengthened, are part of the government policy systems, the guidelines, the standards, and all that is there. So
maybe Rosalind, Rosalind, when you are on that, you could kindly also respond to the question on tendency of teenagers being, so to say, rebellious or curious, and also just this conversation that what we had as Africa or African, maybe the limitation on access to information. We don't have grandmothers anymore sitting around their grandchildren. I think they're more on their phones, on WhatsApp and Skype and Facebook. And so they're not talking. You know, children are getting information anyway, whether you like it or not. So how do we address that? Very briefly, yeah.
I think that becomes a challenge because that's a social norm issue. And when it is a social norm issue, it's not something that just change overnight, or something that you can change because you've heard that our girls are getting pregnant. But then you have to also start by making sure that the guys at the community level, the guys on the ground, get to appreciate that we have dynamics that are changing in society, and there are certain things that we also need to address and change. Appreciate that we have faith-based leaders in the community who also hold a big portion of how the community relates, and how then do we reach them with information that would make them be part of the solution. We have community gatekeepers, the old guys in the community, and they're the ones who will always say, this is what our culture says. So how do you make them come to appreciate that society is changing, society is becoming more open, and there's information that still needs to get out to our children in the correct way, and not in the way that they get it on social media, or the way they get it through other media platforms. I believe in the mantra that nothing is always about us without us. So if it is about us, then how then are we part of the solution? Instead of having solutions that are pushed down our throats, because these are solutions that have worked elsewhere. I worked in Kenya, for instance, and then now I'm working in Zimbabwe. The Kenyan solution is not the Zimbabwean solution. The Zimbabwean solution should be a Zimbabwean solution that has been thought through by Zimbabweans, and just looking through the socio-ecological model that I talked about. So what are the children saying? How does this affect the children? Do the children have a platform to access correct information, communicate their fears, communicate their concerns, even explain why they are rebelling? Because sometimes they rebel because no one is listening to them, or they rebel because the information that comes from out there is not countered by any information that comes from the family or the household with evidence. So then they rebel because they believe in what is out there as having evidence more than what comes from the house. So for me, I believe that it's everybody's problem, even if it's policy, that it has to be everybody participating in influencing the policy. If it's the implementation of the policy, then everybody has to participate in implementing the policy and identifying gaps that arise as a result of implementing the policy to strengthen the policy further.
Thank you. Thank you. Maybe that now that you have the mic, parting shot, Rosalind, and then we'll go along to Nkatha and to Mike, and then I can read out some of the points we can carry for implementation.
I think, so what I would say is that this session came at the right time, because what it does, looking at the presentation from Michael and the presentation from Nkatha and the discussions that are happening, the reality that comes out is that to address teen pregnancies, we all must come together and think of a solution that works for us. And this for us is a start where we are coming together and thinking as different practitioners, different professionals, how we fit within the cycle. Where do we fit in the cycle, and how do we contribute to making the cycle complete? And if we start this way, then it will work. I tell my colleagues at work that we have very superb parenting models that are working for communities out there, but they're not working for us and our children, because we've not thought about us as people who are also raising teenagers who might be pregnant, and maybe because they have access to money or they know where to access services, might be pregnant and even have an abortion before I know.
Thank you. Thank you. Nkatha?
Thank you, Sam. I think a lot has been said, and I'm trying to read through the comments, and I think there's quite a lot that we could address, which I don't know if we'll be able. There's a question of the condoms question that has been addressed by Michael, but let me just say something about it. Because it's just to emphasize what Michael said. You know, obviously, sex issues are very difficult for parents to address. And the question of contraceptives is one of the even more difficult questions for people to address, because the starting point is always, why are we discussing this when it is about children in the first place? But that in itself is actually part of the problem, that most of the time when we are having this sexuality conversation amongst children, we are from the gatekeeping point of view. And because we are doing gatekeeping, we tend to get very protective around children. One, what it does is that while it's a good model, it really also discounts the agency of children. And one of the things that I would want to emphasize is that this conversation need not be about teenagers, it needs to be with teenagers. We need to be able to facilitate participation of children themselves. That's one. But second thing related to that is that because of the protective approach, we then tend to de-emphasize the role of these conversations in teaching positive health-seeking behavior, particularly as it relates to sexuality. I mean, not everyone are having sex, but they're not necessarily getting pregnant, but they're getting other consequences, things that we don't know about. We should be concerned about that too. There is a mental health element to this. There is a mental health element that doesn't only affect girls, it also affects the boys who are involved in these issues. So there is that I mean, again, to re-emphasize that it's a complex conversation, but when we think about things, let's think about the opposite of it. If you think about access to condoms, think about those who are not accessing condoms, yes, but what are the reasons behind, and what are the defining factors of how they express their sexuality? The truth is, when you cannot bear something that the birth of something that has come, its time has come. We are in a large part of our frustration, or my personal frustration, is we try to apply the principles that have worked in the 20 years ago to the present generation. We need to think about those things now and see how a teenager living in today's world is experiencing the world differently from how we experienced the world when we were growing up. You know, our vulnerabilities may be the same, but the external factors that are influencing how we are responding to those vulnerabilities are not the same. So we need to also just acknowledge that reality. In terms of approaches, I think for me, one of the main takeaways is that blanket policies don't work. We need to all think in a manner that the law allows discretion and it allows nuance. It allows us to be so nuanced that we are able to assess the individual circumstances of each child. Because just to generally say that all children who are behaving in a certain way are equal to this, that is contrary to human rights, and it is contrary to the best interest of children. We need to allow ourselves to engage with the individual needs and circumstances of every child. Sounds a bit complex, but it's not as complex actually, because if you put it in policy, you transfer the duty to duty bearers, and people should be conscious that you should approach every child individually. That's one. Secondly, language is a very important thing, especially in law. If you criminalize normal behavior, you already stigmatize it. And when you stigmatize it, you remove it from regular conversation. You make it about a narrative about crime and punishment. And that does not solve issues for adolescents. If anything, it's clear that if you criminalize normal adolescent behavior, the consequences are lifelong and they're extremely deleterious. So let's also just be conscious about the language. There is a very deliberate choice of using adolescent as opposed to child when we talk about sexuality. It's deliberate because, you know, people often, our socialization is very binary. And our socialization is binary in the sense that there are certain things that we think only adults do and only children do certain other things. And one of those is sexuality. And so because, you know, child and adult is a very binary dynamic, when you say adolescent, it allows you to see that this person is forming into a capacity. So let's also be conscious about how we are applying the language when you're talking about sexual and reproductive rights. I mean, it's just, you know, it could veer the conversation one or another. People have certain images of child, very different from images of adolescent. I know it sounds minute, but I know in practice it's very important. And the last thing I think is we need to unlayer and demystify the whole concept of sexual and reproductive rights as far as it applies to children. It's not a foreign concept. There are ideas that are not contextualized to us. I think we need to also talk about those in the sense of we need to agree with ourselves what is relevant in our context. But so long as we push everything out, then we never even get to the point where we say this is not relevant to us. So we do need to have that safe space, safe intellectual discussion about issues that are relevant to us and those that are not relevant to us. And of course, that is where we'll be able to unpack this so that we see, okay, so adolescents are getting pregnant, but they are getting pregnant within that there is child marriage, there is sexual abuse, there is poor sexual conduct choices. Those things are different, the responses are different. Unless you unlayer them, our responses will be too simplistic and they will address some sections, but they will not address certain other issues. And finally, we need to unstigmatize adolescence. Adolescence is not a disease. And I think there's an overwhelming sense in which there's people, within the society thinks adolescents are rebellious, we are fighting with them, it's always a battle. Yeah, that's a manifestation of it, but it's a stage of development. And I would just urge us, for those of us maybe who are not lawyers, who are not doing this regularly, let's also just read the general comment of the CRC, particularly the general comment on children's rights in adolescence. It will give you a lot of perspective about how we need to balance these issues or why they are relevant. Thank you.
Thank you. Mike?
Agreeing with a lot of what has been said by both Roslyn and Nkatha. I just don't want to repeat that, but let me just say that if change is going to be experienced in this particular issue, it has to involve everyone. We have to have a social movement that's driven by everyone in society, appreciating that this is an issue, but also appreciating that there are different, it's not one confluent population that we are talking about. There are, in that 4,000 teenagers who got pregnant, within that same county, there were 200,000 other girls who are actually not even sexually active. So we have to think about how do we not stigmatize these 4,000, yet also ensure that these other 200,000 are protected, they have the right information, and they're celebrated for making the right choices for their own lives. And for the ones who were, lacked in any particular aspect, we have to have a social movement that says, no, this has to stop. At this point, we have to, address whatever drivers are there within your own localities. And I really insist that this cannot be driven by politicians. This can only be driven by people outside politics. And I'm looking to civil society. If we can step up, stick our neck out, and just make sure that this happens for our girls. The other thing is we need data. We need data. What works? We don't know what works. How do we layer all these services within the different settings that these children are going to? There are health facilities. There are some who are in school. There are those who are out of school. There are combinations of what works that is not clear. And we love places where we are seeing evidence of showing real promise, like what Roslyn presented. We should be going to such places to gather evidence and see how we can adapt it to our local situations and make sure that it works, and also make sure that we have data that helps us make informed decisions as we move forward.
Wow, thank you, colleagues, friends. I'm sure we could still keep this conversation going, and it needs to continue. I think just quick summary from what I hear from everyone. Number one, the data is showing that globally and perhaps in Kenya, we need to dig more further, that the trend is actually that perhaps teenage pregnancy is dropping. Could be factors of education, but perhaps could also be that they're not going to clinics, so perhaps we are not reporting as many. But whatever the case, that one unplanned teenage pregnancy, or teenage pregnancy for that matter, is one too many, and we cannot be comfortable just because we have one or so. The other one is like Mike has emphasized, this needs sustained conversation, a sustained social mobilization and social movement driven by civil society, driven by data. And I feel very challenged as being in AICS, and with this pool of experts that we have, about 96 of us across the globe. We should be, the government should be turning to us, or we should be knocking the government doors and saying, look, here are solutions. So thanks a lot, Roslyn, for pointing us to some solutions that we can use. I think that's really the way to go, where we don't speak like everyone else in the street, but we're able to come and say, this works. I think I also see a need for long-term research. I think these are those things where you need a cohort study. Follow a group of 12-year-olds and interventions that were done to them, maybe by their fathers. How much time did they spend with their fathers over 10, 15, 20 years? And then we can say this doesn't work. I think we'll save the next generation of resources by telling them that we tried this and it didn't work, and here is the data that says that. We've got to go back to the old age solutions that have worked, keeping girls in school, keeping them confident girls. I think that will be very, very important. So it should be a big concern what is happening when they're out of school now due to COVID. And like we pointed out that the April to June kind of data may not be COVID yet. This may come out in September or so. So, you know, the numbers are not yet out. We pray that it will not be anything, a major spike. But whatever the case, like we've said, even one case is too much. So what can we do to do a prevention right now? Let's have the conversations. Listening to all of us, I think a rights-based approach is what we are talking about. Empower the child, empower the family, and also empower the service delivery systems, the government system, the health systems, so that if children do have access to the right to access contraception, is it accessible? Is the health facility accessible? Are the healthcare workers ready to listen to an adolescent? And the fact that criminalizing is not going to work just on that. Yes, there are exploitation cases, there are violence cases, there are fathers who've been reported as having impregnated their own daughters. The law needs to demonstrate that that is not accepted, but that alone is not going to work. And we've got to have an empathetic and sympathetic approach, like Dr. Nkata has said, how the CRC has approached this. How do you support teenage mothers? I like that. I don't think that conversation is happening. And as Mike also says, how do you also celebrate those who've been able to manage to go against the peer influence, the pressure that comes with this period? And that we need 2020, or like others say, 2020 solutions. You know, we can't keep going back to 1972 solutions because things have changed. Very important that we can't miss this child-led conversation, that we need to have the conversation with the teenagers, not on the teenagers. I think that's very critical. Again, back to all of us in AICS, let's document these models. Let's share packages of guidelines that you've used, research material that has worked up, and I believe we can make a big difference. If the panelists allow me, we will save this for this recording and perhaps share it on YouTube so that those who have not been able to hear could be able to hear. I think this needs to get to everyone else. Otherwise, thank you for those who participated, those who asked the questions. Let's keep this kind of way of providing solutions. Thank you very much.
Thank you. Thank you, Sam. Thank you, everybody.